Now it's my distinct honor to introduce Professor Dr. SriniVas Sadda, and he's going to be talking about the roles of OCT A in dye-based angiography in retinal disease in clinical trials from the point of view of a reading center. Vas?
Carl, thank you, and congratulations, Carl, Rick. Thanks for inviting me and organizing this one-of-a-kind and first-of-a-kind swept source OCT and OCT angiography conference. So as Carl mentioned, I've been tasked with talking about a reading center perspective towards OCT angiography, and specifically trying to define how we think about OCT angiography versus dye-based angiography in the context of clinical practice and clinical trials. And we're fortunate to be in this era of technology where we have these multimodal imaging capabilities. And so we have to sort of figure out, well, when we're designing a new trial, how do we use these different technologies? These are my disclosures. So, I have a very simplistic viewpoint towards how to do this. And I think when you're trying to define the optimal roles for OCT angiography and dye-based angiography, you really need to think about what are the advantages and disadvantages of the two techniques. So of course, dye-based angiography, fluorescein, ICG, these have been the gold standard for decades for how we image and study the posterior segment, and for good reason, because they have many advantages. They provide excellent resolution of the microvascular detail, at least centrally. They give us dynamic information, things like speed of transit. That's actually informative for many diseases. It allows us to visualize something, sort of a functional type of metric of sorts, I guess, in terms of leakage and staining. And that provides us an ability to distinguish between many different types of diseases. And of course, we have dye-based angiography available to us on wide field platforms as well, so we can study neovascularization or other abnormalities of the vasculature in the retinal periphery. Despite these many advantages, though, there are disadvantages. Now, it does involve a needle stick, so it is invasive. You can potentially rarely get other problems and complications. But the biggest challenge is it's time-consuming. It takes several minutes, and this really requires a skilled operator, I believe, to get the best quality images. The other thing is that, and I'll emphasize this point through the course of this presentation, is that the depth resolution is somewhat limited. And I pointed out that you get nice visualization of the capillaries, but really it's just a very central macula that you can see them in. Outside of this area, they're not really well seen. In fact, there's this very nice paper by Max Snodderly where they did a correlation between histology and fluorescein angiography. And what they observed was that, I don't know if I have this, I don't know where the pointer, oh, here's the pointer. So yeah, as I was saying, I was pointing out that with dye-based angiography, as you get further away from the foveal center, our ability to visualize the capillaries, especially the deep capillaries, really starts to diminish. And I think we all innately recognize that. So what about OCT angiography? Let's run through its advantages and disadvantages. So Michael actually nicely alluded to some of the very important advantages. Obviously, it's non-invasive, it's fast. We can do it on our OCT platforms that we all use in clinic, which Michael alluded to this. So in any event, the nice thing about having this capability is, as Michael also pointed out, we can do it frequently. And this is very powerful and useful for longitudinal studies. Also, we get spectacular vascular detail. Rick Spade was one of the first to point out that one of the things that we never saw before with fluorescein angiography was this radial parapapillary capillary network. I'll point out how this is, I think, going to be an extremely valuable tool for us for following a number of different diseases. And of course, you can even do other manipulations. You can average multiple frames. We're used to the concept of averaging in OCT, and even further improve our ability to visualize the vascular detail. And this is where I think swept source OCT, again, has another advantage because of the faster speed. It's easier to do this type of averaging. In addition, of course, it's not just for the retinal circulation. Michael showed spectacular cases. Carl was kind enough to help me with a few slides here as well, that we can see considerably more detail, for example, of the choroidal vascular lesion. We can actually see the larger vessels as opposed to just this area of staining or leakage that we might see with fluorescein angiography, just some more examples. And of course, this type of, this is another case to illustrate that. Again, you sort of see the choroidal vascular lesion here. You can see some leakage, but you really can't make out the vascular detail, which again, OCT angiography affords us. But I think, where it really shines, I think, especially as we think about clinical trials now, is in the context of retinal vascular diseases. This is a patient of mine with a relatively mild vein occlusion. You can see a little bit of leakage on fluorescein angiography, but you can recognize even in this patient, there are subtle alterations. There are areas of capillary non-perfusion that you can see even early on. But what's especially exciting now is that we can recognize that those capillary alterations not only involve the superficial, but also the deeper circulation. That's what's actually possible with OCT angiography, which brings me to my next major advantage of OCT angiography when we think about the context of clinical trials, is this depth resolve. We're able to access information from the superficial as well as the deep circulation, as shown in this example. And now we have very sophisticated algorithms that our devices provide us, allowing us to segment the superficial and deep capillary circulation. And we see that they can be differentially affected by disease. This is another example of a patient with diabetic retinopathy. You see the significant non-perfusion in the superficial circulation, but you can see that the deep circulation is also impacted. And of course, we don't have to stop there. We can go down section through the outer retina and actually visualize the choriocapillaris as well. But it's this great contrast, this ability to actually distinguish vessels from non-vessels that really lends OCT angiography to quantification. And when you think about OCT, what made OCT really take off? One of the things, in clinical trials at least, was that it gave us automatic quantitative information. So that's something that OCT angiography can give us as well. And so we're able to, for example, do very simple operations, binarize the image into either vessels or non-vessels, and then skeletonize it, and then use that to compute various quantitative parameters. We and others have published many papers. I think many here in the audience have published papers on this concept. Whether you look at capillary density or even in diabetic retinopathy, you could even look at just the FAZ. The FAZ varies considerably in normals, but it turns out, not surprisingly, that it's further enlarged in patients who have retinal vascular diseases like diabetic retinopathy. So I think looking at these quantitative measurements in retinal vascular diseases is going to be very important in clinical trials moving forward, especially since we have pharmacotherapeutics like anti-VEGF therapy that actually affect the underlying retinopathy. So to be able to quantify the retinal circulation, I think, is going to take new importance. We recently actually published a paper where we looked to see what is the impact of anti-VEGF therapy on retinal vascular perfusion. In this, let me go back here, sorry. In this particular study, we didn't actually find an effect, as a paper published in IVS a few months ago. We didn't find an effect of anti-VEGF therapy, but that's something that we'll be looking for moving forward. Of course, we can do the same thing in terms of quantification of choroidal vascular lesions. Nadia has done a lot of work in this area, where certainly you can visualize the choroidal vascular membrane, you can measure its area on OCT angiography, and you also have an opportunity to look at its vascularity, if you will, because you can separately isolate the vessels and look at the percentage of the vessels that occupy the choroidal vascular membrane. These are now new metrics that we'll have available to us in future trials. I think it's pretty exciting. So I alluded to this earlier, and I think this is going to be a huge application of OCT angiography. This is a paper we published a few months ago about looking at a variety of different optic nerve disorders. This happens to be a case with Leber's, and you can track actually the capillary loss in the radial peripapillary capillary network over time in these individuals. But you can imagine, for example, a patient with papilledema, if you're trying to see like how acutely do I need to get down their ICP, for example, in a pseudotumor patient, and the neurofibrillary is swollen. Hard to assess the neurofibrillary thickness. That's not going to help you. Visual field may be a bit of a challenge in such an individual, but you could do OCT angiography and track what's happening to the microcirculation. So I think that's going to be a powerful application. Another huge application, this is a paper we published last month, in glaucoma. And we find that looking at the radial peripapillary capillary network can be very useful for distinguishing patients who are normal from pre-parametric glaucoma to patients who have glaucoma. So I think this is going to be another very powerful application of OCT angiography moving forward into the future. Okay, so made it sound great, and it is great, but you have to recognize that there are also disadvantages. And one of the disadvantages is that there's a limited velocity range. So you might not visualize everything you want to see. So you might not visualize some slow fold lesions. For example, microaneurysms. This is a very nice paper from Jim Fujimoto and Nadia Wahid, where they looked at a comparison between fluorescein angiography and OCT angiography. And yes, as Michael pointed out, you can see many of the lesions, including many of the microaneurysms, but not all of them. In fact, one of their conclusions was that they identified substantially fewer microaneurysms on OCT angiography than fluorescein angiography. Some of that may be related to flow. There may be other issues as well. Similarly with polyps, Jemmy Chang is going to give a talk later on, and they published a very nice paper on this concept of the fact that you can see polypoidal disease, you can see polyps in OCT angiography, but not all of them. In fact, they concluded in their paper as well that, I don't know if you can read this, but that swept surface OCT angiography is inferior to ICG for detecting creating these polyps. So we can't do everything. We can do many things, but not necessarily everything with OCT angiography, and that's where dye-based angiography can still have a role. There have been many publications now that have looked at the sensitivity of OCT angiography for detecting choroidal vascularization. Depending on which paper you read, it can go anywhere from 60 to 90%, higher for type 2 lesions. But again, keep in mind, none of us look at OCT A in isolation. We look at it with our structural OCT, and I think when you do that, your detection sensitivity really is quite high. But it can be a challenge sometimes. Here's a patient of mine with a wrap lesion, and yeah, I could find the wrap lesion, but I really had to know that I was looking for it. I suspected it based on the structural OCT, and we could find it. But it's just an illustration of how it's not always easy. I will say, though, that, and Michael also pointed this out, specifically in patients with pachychoroid diseases that Rick talked about, sometimes you have chronic pachychoroid changes, a lot of RP alterations. It's hard to tell, is there actually leakage on the fluorescein? This is where seeing the vessels on OCT angiography can be very powerful. Another example of where the limitation of the velocity range manifests itself is in patients with GA. This is a patient with geographic atrophy, and you can see the margin of the atrophy here, and you can see in the area where there is atrophy, the loss of the RP and the choriocapillaris has allowed us to see the flow signal in the choroid much better. We can also see that there are areas where there is partial preservation of the choriocapillaris, which Giovanni Storengi has pointed out is a difference between atrophy in AMD versus Stargardt's, where you really don't have any preservation of the choriocapillaris. What's interesting, though, is to look at the other side of the margin of these lesions. And again, this is another example of a patient with GA, but I wanted to point out, here you have intact choriocapillaris, here you have absence of the choriocapillaris, and you're seeing the larger vessels. But here at the margin, you see these kind of areas of what appear to be reduced flow, these somewhat relatively dark areas. And this is something that Nadia and Jim had studied very well with their VISTA analysis, where they demonstrated that if you actually change the interscan time between the OCT A acquisitions, you could actually, by going to a longer interscan time, some of these dark areas at the margin of the GA lesions actually started to fill in. And so they were able to suggest that maybe there were different speeds of flow, maybe a reduction or an impairment, but not necessarily an absence. But even with this analysis, I'd point out that we still have relatively limited velocity resolution with OCT angiography, and that remains still a key challenge. Michael also pointed out how we don't visualize leakage. Again, you can see this nice illustration from Nadia's paper where you can see the leakage in this diabetic patient. You don't see that in OCT angiography. Similarly with choroidal vascular lesions. The same thing. We can see the vascular architecture. We can't tell if it's leaking or not. Another big challenge, of course, is artifacts. You can have problems with, you have to get the boundaries segmented correctly. Michael talked about, you have to pick your layers, and sometimes it can be a challenge. Here's an example of a patient of mine, the choroidal vascular membrane. We can all see that. But you can't really detect its margins, and that's because it kind of blends into the choriocapillaris because of how the segmentation was selected. You can also have segmentation artifact like this, where it's a sort of a focal artifact. This patient we thought might have choroidal vascularization, but it's not. It's actually because there happens to be a tiny little segmentation error. If you correct that segmentation error, it disappears. So these are all things that you need to keep in mind. And then, of course, manual correction of these kinds of things is tedious. And, of course, we have many different instruments. How do you standardize? That's something that we're still working on. Motion artifact is another problem. Projection artifact, we didn't really talk a lot about this, but you have to be able to know that you can see that there's reflections from deeper layers. That can be confusing in interpreting these images. Also, we really can't do wide field all the way to the periphery yet. You can montage scans, like these nice images from Carl. But they can potentially partially address this, but it's still a limited field of view. And of course, the biggest thing is, from a reading center perspective, we need to know how repeatable is this information. That's how you can judge whether the data is really useful. And of course, we've done a number of these kind of repeatability studies, and we find that the repeatability is actually pretty good, that you can trust these density measurements with a repeatability less than 5%, which is great. But probably the biggest challenge is we really need to have clinical trial data. That's, I think, going to be forthcoming because that's going to tell us how to use this information. I'm going to finish here in just a moment. There are some applications that I think we're already thinking about just based on case studies and even without large clinical trials. One of them is MACTEL. This is a patient of mine who has MACTEL. We can see, I'll just go forward, you can see the capillary telangiectasia. In this case, I think OCT angiography is great for detecting MACTEL. We'll move forward here because I'm out of time. And this is another patient. That was MACTEL type 2. This is a patient with MACTEL type 1. really can beautifully see the telangiectatic lesions on OCT angiography. I really think it's quite spectacular. Another patient with sickle cell disease, you can see the infarction here in this particular patient. You can see the peripheral neovascularization on this eye. You can see the macular abnormalities here. But we can really appreciate much better on OCT angiography. Even in the right eye where there was not a macular lesion, we can see that there are areas of capillary loss. In the left eye, we really can see the areas of capillary non-perfusion really quite well. And lastly, I want to leave you with this case, which I think accounts for a potentially very powerful new application for OCT angiography. Michael alluded to this as well. This diabetic patient with neovascularization, we can see it on OCT angiography. And of course, now with Protocol S results from DRCnet, we're treating many of these patients with anti-VEGF therapy. You can see how it disappears with anti-VEGF therapy. Now we're trying to figure out how do we manage these patients going forward? When do we figure out when to use anti-VEGF therapy again? This is where this concept of using this for endpoint management, this concept of sentinel nevascularization, I think is potentially very useful. So to conclude, putting this all together, from my perspective, I think OCT angiography has largely supplanted dye-based angiography. We're looking at non-perfusion, and we can do it repeatably, as I've shown. I think it's sufficient for diagnosis of certain disorders such as MACTEL. I think it's an important adjunctive tool for corneal nevascularization, particularly in the setting of pachychoroid disease, but I think there's still a role for dye-based angiography here so far. OCT A alone, I think, is insufficient for excluding the presence of CNV or polypoidal disease, but it may be sufficient when combined with structural OCT in some cases. I think that this concept of OCT A-guided management for retinal diseases holds promise for the future, but we really need clinical trial data. And I do think that, because we don't see leakage, because of these issues, I think dye-based angiography is going to retain its role for looking at inflammatory diseases and when you have to look for leakage. For example, in the setting of retinal vascular disease. And I think for now, at least, dye-based angiography retains its role for assessment of the vascular and the retinal periphery. Thank you very much, and sorry for the technical glitch.